Okay, let's unpack this. You know that feeling. Your head's pounding like a drum solo gone wrong, maybe.
Yeah,
Or maybe it's that dull ache that just sets up shop behind your eyes and just refuses to leave.
right.
Yep, the humble headache.
Yeah.
We've all been there, probably frantically searching online for some miracle cure while trying to figure out if it's just stress or something. Well, something else.
Oh, yeah. That digital rabbit hole can be a confusing place when your head is throbbing. Sorting through all that info to find what's actually trustworthy and, relevant to you can be a headache in itself.
Absolutely. So for this deep dive, we've done the heavy lifting for you. We've plunged into, well, the depths of medical literature and guidelines to map out the headache terrain. Our mission today is really to clear the fog, get a handle on the different kinds of headaches out there, and equip you with some useful insights on what to do about them.
Think of this as your shortcut to becoming headache savvy, maybe. With us as your guides through the, let's say, medical landscape, highlighting what's most important to understand.
And to kick things off, it's really helpful to think about headaches in two main camps,
So,
primary and secondary.
okay.
Here's a simple way to remember it. A primary headache is the main event, the condition itself.
Right. It stands alone.
A secondary headache, on the other hand, is kind of like your head sounding the alarm that something else in your system might be going haywire.
That's a great way to put it. Yeah. Primary headaches are standalone conditions, not a symptom of another illness lurking beneath the surface.
Exactly. And the undisputed champion of primary headaches, the one we've all likely tangled with, is the tension-type headache. Get this, it accounts for a whopping 45 to 70% of all primary headaches.
Wow.
Talk about common.
It really is.
Yeah.
What's fascinating here is just how widespread these tension-type headaches are. You'd probably recognize it as that pain on both sides of your head, right? Often described as a pressing or tightening sensation. It's usually mild to moderate, and importantly, unlike some other headaches we'll discuss, it doesn't typically get worse if you're doing your usual activities.
Right, so moving around doesn't make it flare up usually. You might get a bit sensitive to light or sound, but usually not both at the same time, which can be a clue it's not something else.
Exactly.
And who hasn't had that extra treat of a stiff neck or a tight jaw joining the party? It's like they're sold as a package deal sometimes.
Indeed. And doctors sometimes find increased tenderness when they examine the muscles around your head and neck. That's what's meant by pericranial tenderness.
Okay,
Basically, it's like those muscles are extra sensitive to touch.
got it. Now let's switch gears and talk about a headache that tends to get a lot more buzz. And for good reason. Migraine.
Ah, yes.
This isn't your run-of-the-mill headache. It's a real disruptor, a chronic neurological disorder that often shows up in episodes and can really throw a wrench in your day or even your week.
What's critical to appreciate is the sheer impact of migraine. It's not just a bad headache, it's actually ranked as the most disabling neurological disorder out there, and the sixth most disabling condition globally. These attacks often hit you on one side of the head that's unilateral pain.
Right, one side.
And it's frequently described as throbbing, anywhere from moderately annoying to utterly debilitating. And unlike tension headaches, physical activity will definitely crank up the pain.
Oh, wait.
Plus, you often get that unwelcome trio of sensitivities. Sound, light, and even movement can feel excruciating.
The numbers are pretty eye-opening, too. Globally, around 12% of people deal with migraines, and there's a really significant difference between men and women. About 18% of women experience migraines compared to only 6% of men.
That's a big difference.
It is. And if you zoom in on women in their early 20s, the incidence jumps to around 18 per 1,000. That really highlights how incredibly common this can be for some.
Yeah, and while the why behind that gender disparity isn't fully spelled out in every source, hormonal fluctuations are thought to play a pretty significant role.
Makes sense.
Now, what actually causes migraine is still a bit of a puzzle. Scientists are working hard on it. But the current understanding points to the brain's sensory processing pathways becoming overly sensitive.
Like hyperalert.
Exactly. Almost like a car alarm that goes off with even a gentle breeze. It's believed to start in several areas of the brain and particularly affects the trigeminal system. Think of that as a major superhighway for pain signals in your head.
Okay.
Interestingly, this focus on the trigeminal system, especially the role of CGRP, has led to those newer inhibitor drugs.
Right, the CGRP inhibitors.
Yeah, offering a much more targeted approach than older treatments.
Here's where it gets really interesting. We also learned that about 1 in 3 people with migraine experience something called an aura.
Yes, the aura.
These are like temporary neurological disturbances that usually pop up before or alongside the headache itself.
What's fascinating here is that migraine with aura actually seems to have a different genetic underpinning compared to migraine without aura. These auras can show up in all sorts of ways, but the most common are visual changes, like seeing shimmering lights or blind spots. Those are often called scintillating scotomas.
Flashing lights, weird patterns.
Exactly. But you can also get sensory changes like tingling or numbness, speech or language difficulties, muscle weakness, brainstem symptoms, or even issues with your vision in one eye.
And these aura symptoms usually build up gradually over, about 5 to 60 minutes before fading away?
That's right, usually within that time frame.
It's like the brain is putting on a little pre-show with flashing lights and weird sensations before the main event of the headache.
That's a vivid description. And a typical migraine attack can actually be thought of in 4 phases. First, there's the prodrome.
The warning signs.
Sort of, yeah. Subtle shifts in mood or energy levels in the hours or even days beforehand. So that's like the early warning system kicking in, even if you don't consciously realize it's a migraine coming yet.
Okay.
Then comes the aura, if you're someone who experiences it. After that, of course, is the headache itself. And finally, there's the postdrome.
The headache hangover.
Pretty much. That often draining, sometimes even weirdly euphoric feeling you get after the pain subsides.
Right. Okay. Now let's talk about a type of primary headache that, while thankfully less common than tension or migraine, is notorious for its absolutely excruciating pain. Cluster headache.
Cluster headache, yes. It belongs to a group called trigeminal autonomic cephalalgias, or TACs.
Okay, break that down for us. TACs.
Right. So trigeminal refers to the trigeminal nerve, the main nerve in your face. And autonomic refers to the involuntary responses in your body.
Like tearing, stuffiness.
Exactly. Tearing, nasal congestion, that sort of thing. So these headaches involve that severe one-sided pain, usually around the eye, temple, or forehead.
Always one side.
Typically strongly lateralized, yes. And it's coupled with those autonomic symptoms on the same side of your head. Think of a red, teary eye, maybe swelling around the eye, facial flushing, a blocked or runny nose, even a feeling of fullness in the ear, all happening on the same side as this intense pain.
It sounds absolutely brutal. And the name cluster really makes sense because these headaches tend to come in waves, right?
That's exactly why they're called cluster headaches. Periods of frequent attacks lasting for weeks or even months, followed by periods of remission that can stretch out for months or even years.
Wow.
And the individual attacks can last anywhere from 15 minutes up to 3 hours and can strike multiple times within a single day.
Multiple times a day.
Oof. Yeah. What's fascinating is that the underlying cause seems to involve both a peripheral component related to the trigeminal nerve and a central component with effects on the hypothalamus.
Hypothalamus in the brain.
Yes, a small but crucial area that regulates things like your body clock. The exact mechanism and implications are still being studied, though.
Something really interesting we noted is how people behave during a cluster headache. It's different from migraine, isn't it?
Very different. Unlike migraine sufferers who usually want to lie down in a dark, quiet room.
Right. Total isolation.
People with cluster headaches often become agitated and restless. They might pace around, rock back and forth, or even physically apply pressure to the painful area, desperately seeking some kind of relief.
Wow, that's a stark contrast. Pacing versus wanting to be perfectly still. What do scientists think drives that restlessness? Is it just the sheer intensity?
It seems related to the nature and intensity of the pain, and perhaps that central hyperthalamic involvement too. But that difference in behavior can actually be a really helpful clue for doctors when trying to differentiate the headache types.
Okay. Now, very briefly, there are a few other primary headaches worth a quick mention. We're talking about SUNCT and SUNA headaches.
Right, SUNCT and SUNA, also part of the TACs group. These are characterized by incredibly brief, almost lightning strike-like pains on one side of the head or face.
Super short, super intense.
Exactly. Often accompanied by a red, teary eye or a blocked nose, the key difference between SUNCT and SUNA is really about which of those autonomic symptoms, like the tearing and runny nose, are present. Interestingly, people with SUNCT-SUNA usually don't experience the nausea or sensitivity to light and sound that are common with migraines. The pain itself is often described as burning, stabbing, or even like an electric shock, and sometimes it can be triggered by something as light as touching the skin.
Wow. Then there's primary cough headache.
Yep, rare, usually affects folks over 40. As the name suggests, triggered specifically by coughing. While rare, it's something doctors consider, especially in older patients with new headache.
Exercise headache.
Primary exercise headache, another one. Brought on by sustained physical activity, especially if it's hot or you're at a high altitude. Doctors think this might be related to changes in blood flow in the head.
And finally, coital primary headache.
Right, triggered during or right after sexual activity. So, as you can see, it's a really diverse landscape of primary head pain, even beyond the big three.
Definitely.
It is indeed. And while primary headaches are the ones we encounter most often, it's absolutely crucial to be aware of secondary headaches.
Okay, the ones that are symptoms.
Exactly. Headaches that are actually a symptom of an underlying medical condition.
And surprisingly, infection is the most common reason for these secondary headaches. Something like 63% of cases.
That's right. According to the sources we looked at, we're talking about serious infections like meningitis.
Inflammation around the brain.
Right. Or encephalitis, which
Yeah.
is inflammation of the brain itself, and brain abscesses, collections of pus in the brain.
Okay.
A big red flag to watch out for with these is the presence of fever and or meningitis. Those are things like a stiff neck or pain when trying to touch your chin to your chest.
Right. Signs of irritation.
Exactly. Vascular issues are another really important category of secondary headaches.
Things involving blood vessels.
Yes. This includes different types of bleeding in the brain, such as intracerebral hemorrhage, ICH, subarachnoid hemorrhage, SAH, and subdural hematoma, SDH. It also covers structural abnormalities in the blood vessels, like arteriovenous malformations, AVMs, even things like very high blood pressure and cerebral venous thrombosis, CVS, which is a blood clot in the veins of the brain, can trigger severe headaches.
Subarachnoid hemorrhage, or SAH, sounds particularly serious.
It definitely is. It can be life-threatening. There are some really serious red flag symptoms here, like a sudden, severe headache that feels like the worst headache of your life, sometimes described as a thunderclap headache.
Thunderclap, just bam, instant severe pain.
Exactly. The diagnostic process often involves a non-contrast CT scan of the head, ideally within 6 hours of the headache starting.
Okay, need to act fast.
Very fast.
Yeah.
If that CT is inconclusive but SAH is still suspected, doctors might do a lumbar puncture, a spinal tap, to analyze the cerebrospinal fluid for red blood cells, and something called xanthochromia.
Which shows there's been bleeding.
Right, a yellowish discoloration indicating older blood breakdown products.
Okay. What about that cerebral venous thrombosis, CVS?
Right, CVS. It's more common in younger adults, particularly women of childbearing age and children. Symptoms can include headaches, seizures, changes in consciousness, and specific neurological problems depending on where the clot is.
So diagnosis involves imaging.
Usually requires imaging of the brain's blood vessels, yes. It's also vital to remember that acute ischemic events, like a stroke where blood flow to part of the brain is blocked, can present with a headache in over 25% of cases.
So headache can be a stroke symptom.
It certainly can be. These headaches are often accompanied by other neurological symptoms like balance problems, vision changes, weakness in the face or limbs, and difficulty speaking. A CT scan is essential for diagnosing a stroke.
Got it. Problems with the pressure inside your skull can also lead to secondary headaches, right? Both too high and too low.
Exactly. Increased intracranial pressure, IICP, like an idiopathic intracranial hypertension, also known as IIH or sometimes pseudotumor cerebri.
Pseudotumor. Sounds serious.
It means false tumor because the symptoms can mimic a brain tumor, but there isn't one. With IIH, you might see swelling of the optic nerve at the back of the eye, papilledema, and problems with the sixth cranial nerve affecting eye movement.
How's that diagnosed?
Doctors might use MRI or CT venography to rule out other structural issues, and a lumbar puncture is key because they can measure the opening pressure of the cerebrospinal fluid.
And too low pressure.
Yeah, decreased intracranial pressure. This can sometimes happen after a lumbar puncture or even spontaneously. It causes a specific type of headache that often feels worse when you're upright and gets better when you lie down.
The standing up headache.
Kind of, yeah. Brain tumors, while often a worry when someone has persistent headaches, are actually a less common cause overall.
That's reassuring.
It is. The symptoms can vary quite a bit depending on where the tumor is located and how big it is. Pituitary adenomas are one example, tumors of the pituitary gland at the base of the brain. They can cause headaches along with visual problems and hormonal imbalances.
Okay. And finally, issues outside the skull, like temporal arteritis.
Right, extracranial issues. Temporal arteritis, also called giant cell arteritis, is an inflammation of blood vessels, particularly in the head. A key clue here is a headache in the temple area, often accompanied by pain in the jaw when chewing, called jaw claudication.
Jaw pain when chewing.
Yes, that's a classic symptom. This is something that doctors are more alert for in older patients, usually over 50.
Okay. So with this huge array of potential headaches, how does someone even begin to figure out what's going on when their head starts to pound?
That's the million-dollar question, isn't it?
Yeah.
Well, getting to the bottom of a headache really starts with a thorough medical history and a physical examination, especially a neurological exam. Doctors are on the lookout for those red flags that might suggest a secondary cause.
The warning signs.
Exactly. There's a handy mnemonic doctors sometimes use for this. It's called SNOOP10. It helps them remember key things.
Okay, SNOOP10. What does that stand for?
Let's see. Systemic symptoms like fever or weight loss, history of neoplasm, cancer, any new neurologic deficits like weakness or numbness, sudden onset of the headache, especially that thunderclap type, older age of onset, like over 50 for a new headache type, a pattern change in existing headaches.
So if your usual headache suddenly feels different.
Precisely. Then there's positional headache, or standing or lying down, headache precipitated by coughing, sneezing, or exercise, papilledema, that optic nerve swelling we mentioned, and progressive headache that's worsening over time, or other atypical features. It's quite a list.
Wow, that covers a lot.
It does. What's insightful here is how this mnemonic provides a structured way for clinicians to quickly assess if there's a higher chance of a serious underlying condition.
Makes sense.
If none of these red flags are present, it makes it much more likely that the headache is primary.
Back to tension, migraine, cluster.
Exactly. And as we discussed earlier, those primary headaches are then differentiated based on specific characteristics, frequency, location, duration, quality of pain, triggers, and whether or not there's an aura.
And imaging, like CT or MRI, not usually needed for typical primary headaches.
Generally, no, not unless there are red flags or atypical features suggesting a secondary cause. Then imaging becomes important.
Okay.
And as we mentioned before, a lumbar puncture, the spinal tap, is a key diagnostic tool when there's concern about things like subarachnoid hemorrhage, infection, inflammation, or even certain cancers affecting the brain, or spinal cord lining.
Got it. Are there simpler tools, too, like questionnaires?
There are. For example, there's the ID migraine screen. It's just 3 quick questions using the acronym PIN.
PIN?
Yeah, P for photophobia, does light bother you during headaches? I for impairment, how much does it limit your activities? And N for nausea, do you feel sick to your stomach?
So light, impairment, nausea.
Right. A yes to 2 or more of those significantly increases the likelihood that someone has migraine. It's a simple screening tool.
Useful.
It's also really important to be aware of medication overuse headache, often abbreviated as MOH.
Ah, yes, the rebound headache idea.
Yeah. Kind of, yeah. It can unfortunately happen when you frequently use pain relievers to treat your headaches, especially certain types like opioids, medications containing botaloidal, and those combo drugs with aspirin, acetaminophen, and caffeine.
So taking painkillers too often makes headaches worse.
It can lead to a pattern of more frequent, often daily, headaches that are harder to treat. To avoid this, the general guideline is to limit the use of most acute headache medications to less than 10 days per month.
Less than 10 days a month. That's a key number.
It really is. It's a tricky situation where the treatment itself can actually perpetuate the headache cycle.
Okay, so let's talk about what to do when a headache strikes. What are the typical treatments for these different types? Starting with tension type again.
Right. For those very common tension-type headaches, the acute treatment, meaning what you take when you have one, usually involves over-the-counter pain relievers like NSAIDs, ibuprofen, naproxen.
Standard stuff.
Yeah, and acetaminophen. For people who experience chronic tension-type headaches, meaning they happen very frequently, like 15 or more days a month.
That's a lot.
It is. Then preventative treatment might be considered. This could include medications like certain tricyclic antidepressants, amitriptyline is a common one, or other options like mirtazapine or venlafaxine.
Okay.
Interestingly, non-drug therapies can also be really helpful for chronic tension headaches. Things like biofeedback, relaxation techniques, cognitive behavioral therapy, and even physical therapy can play a significant role in managing them.
So it's not just about pills.
Definitely not, especially for the chronic forms.
Okay, what about migraine treatment?
When it comes to migraine, the approach to acute treatment can vary. It can range from those simple over-the-counter pain relievers, if they work for mild attacks.
Sometimes they do.
Right. To more specific prescription medications like triptans. Sumatriptan is a well-known example. There are also antiemetics to help with nausea, like metoclopramide.
For the sickness.
Exactly. And then there are newer drug classes like the CGRP antagonists, both oral ones for acute treatment and injectables, lasmiditan and dihydroergotamine, DHE, which is an older but still effective option.
Lots of options.
There are. Sometimes combining a triptan with an NSAID, there are actually specific combo pills available, can be even more effective for some people.
Okay.
There are also neuromodulation devices now, which use electrical or magnetic pulses as an option for individuals who maybe can't tolerate or don't respond well to medications.
Devices, interesting.
Yeah. It's worth remembering that triptans are generally avoided in certain less common types of migraine with aura, like hemiplegic migraine where there's weakness. And that reminder again, limit how often you use acute migraine medications to prevent MOH.
Right. Less than 10 days a month. What about preventing migraines?
Preventative treatment for migraine is often very personalized. It's tailored to an individual's specific triggers, the frequency and severity of their attacks, and other health conditions they might have.
So finding what works for you.
Exactly. First-line preventive medications include things like beta blockers, propranolol, metoprolol, some antidepressants like amitriptyline or venlafaxine, certain anticonvulsants like topiramate or valproate.
Anti-seizure meds.
Yes, some of them work well for migraine prevention. And then there are the newer CGRP antagonists, which are available as monthly or quarterly injections or even daily pills for prevention now.
Wow, lots of developments there.
Absolutely. And again, lifestyle modifications can be very beneficial too. Things like regular aerobic exercise, biofeedback, relaxation techniques, CBT, and even acupuncture has shown some evidence.
Okay. And cluster headaches. Treatment sounds urgent.
Extremely. Because the pain is so severe and comes on so quickly, acute treatment aimed at stopping the attack is really critical. High-flow oxygen therapy is actually a first-line treatment.
Oxygen.
Yes. Inhaling 100% oxygen through a non-rebreather mask can be very effective for many. Triptans, often given by injection or nasal spray for faster action, are another common abortive strategy.
Faster routes than pills.
Right, because the attacks are often shorter. And because of the cyclical nature of cluster headaches, preventive strategies are also really important to try and reduce the frequency and severity of the clusters. Verapamil, a calcium channel blocker, is a common preventive medication.
Okay. And those SUNCT, SUNE ones, you said they're tough to treat.
They often are, yes, quite refractory to treatment sometimes, but some preventative options that have shown some benefit include certain anticonvulsants like lamotrigine, lithium, and sometimes short courses of glucocorticoids like steroids.
Got it. So when we step back and look at all of this, what's the broader impact of headaches on, us, the public?
Well, it's so important for everyone to remember that the vast majority of headaches are a primary tension-type migraine, and thankfully not a sign of anything immediately life-threatening.
That's the main message.
It is. But being able to recognize those red flags we talked about is absolutely vital for identifying the small percentage of headaches that could be a symptom of a potentially serious underlying condition.
Knowing when to worry, basically.
Exactly. We also need to understand just how much of a burden headache disorders are globally. They are a major contributor to disability worldwide. Think about missed work days, missed school days.
Impact on life quality.
Huge impact on quality of life, ability to function, social activities, everything.
This really highlights the importance of seeking professional medical advice if you are experiencing frequent or severe headaches, or if you notice any of those red flag symptoms that we discussed. Don't just ignore it.
Absolutely. Getting an accurate diagnosis is the first and most crucial step towards effective management and ultimately improving your quality of life. You can't treat it effectively if you don't know what it is.
Makes sense.
And it's worth repeating that being mindful of how often you're taking pain relievers is key to avoiding that medication overuse headache trap.
Right. Okay, so to bring this deep dive to a close, we've explored the fundamental difference between primary headaches to the main event and secondary headaches, the symptom. We've highlighted the key characteristics of the most common primary headaches, tension type, migraine, and cluster, and touched on some of the less common ones.
Right.
And we've really emphasized the importance of being aware of when a headache might be a warning sign, a red flag, for something more serious that needs prompt medical attention.
This leads us to a really important point for you, the listener. How well do you really know your own headaches? Have you ever paid close attention to when they happen, what they feel like, what might be going on around that time?
Exactly. Our thought-provoking idea for you to take away today is to become a bit of a headache detective in your own life.
Yeah, put on your detective hat.
Consider keeping a simple headache diary. Just jot down when your headaches occur, how long they last, what the pain feels like, throbbing, tightening, one side, both sides.
And any potential triggers you might notice, things like stress levels, changes in sleep patterns, certain foods or drinks, maybe even the weather.
Right. This kind of detailed information can be incredibly valuable when you talk to a doctor or other healthcare professional about your head pain.
It really empowers you. It helps you have a much more informed and productive conversation.
Yeah, instead of just saying, I get headaches sometimes.
Exactly. It could potentially lead to a more accurate diagnosis much faster, and ultimately a more effective plan for managing your specific headaches and getting some relief.